So let's talk about gallbladder and biliary tree now. And first, let's talk about the anatomy of the gallbladder. Now, you know that gallbladder is pyriform in shape, right? It is pyriform in shape. And the reason why I'm telling you, I'm sure most of you are aware of this, it's pyriform in shape. But the reason why I'm telling you this is that there are two things. Either you can have a distended GB, and distended gallbladder can be seen in a patient with obstructive jaundice due to periampullary cancers. This I've covered in the pancreas module, due to periampullary cancer. Or you can have an enlarged gallbladder in patients with GB cancer. And how we differentiate the two gallbladders is that when there is a distended gallbladder, it retains its pyriform shape. It retains its pyriform shape, and there is some side-to-side mobility as well. Side-to-side mobility can also be there on examination. But when it is a GB cancer, the pyriform shape is lost. Pyriform shape is lost and it becomes a gallbladder mass. This I've even covered in one of the abdominal cases which I've covered in the modules. So this is a very important point to know on examination when you're examining a patient who has a palpable gallbladder. Okay. So this was the first thing which I wanted you to know. I also want you to know that gallbladder, it lacks submucosa. It lacks submucosa. Okay. Another thing is that there are subserosal lymphatics which are present in the gallbladder, and these subserosal lymphatics which are there, they drain into the liver. They drain into the liver, and this is one of the ways how gallbladder cancer, this is one of the way how it can go into the liver. I'll tell you about the two other methods. One is by direct infiltration and third is by hematogenous route. Those are the three ways how gallbladder cancer can metastasize into the liver. So these are the three ways gallbladder cancer can metastasize into the liver. Another thing which I want you to know, that there is a valve of Hista which is present in the GB neck. You have a valve of Hista which is present in the GB neck, and you know the functions of gallbladder. The functions of gallbladder, it acts as a reservoir for bile. It secretes mucin, and it helps in concentration of bile as well. It helps in concentration of bile as well. Okay. Another very important thing, and this is particularly important when you're doing a laparoscopic cholecystectomy, there are two triangles which are there, and I want you to understand them. So this is the liver. This is the liver. This is your right hepatic duct. The left hepatic duct forms the common hepatic duct. Then you have the cystic duct, you have the gallbladder, and you have the CBD, okay? So the first triangle is bounded by the inferior edge of the liver. This is the inferior edge of the liver. You have the common hepatic duct here. This is the common hepatic duct, and you have the cystic duct. So this is the first triangle which is there. Inferior edge of the liver, common hepatic duct, and the cystic duct. This is not the Calitz triangle. Mind you, that is what I want to highlight. This is not the Calitz triangle. This is known as the cholecystohepatic triangle. This is the cholecystohepatic triangle, not the Calitz triangle. Inside the cholecystohepatic triangle, you have the cystic artery. This red one is the cystic artery, right? Cystic artery is a branch of the right hepatic artery. This is the cystic artery. Now this triangle which is formed by the cystic artery, cystic duct and the common hepatic duct, the one which I have shaded as yellow, formed by the cystic duct, the common hepatic duct and the cystic duct, this is known as the Calitz triangle. So Calitz triangle is a smaller triangle inside the bigger cholecystohepatic triangle. That's what I want you to understand. And the Callett's triangle also harbors the cystic lymph node of Lund. It harbors the cystic lymph node of Lund, which is the first lymph node to be enlarged in gallbladder cancer. So this is there in the Callett's triangle, which is the first lymph node to be enlarged in gallbladder cancer. Now, the reason for highlighting these two triangles is that when we are doing a laparoscopic cholecystectomy, we need to delineate the anatomy so that we can clip the cystic duct and the cystic artery properly. Let me just show you an image. This is an image of a lap chole, and you can see here that we have delineated, this is the cystic artery, this yellow one, this is the cystic artery, this is the cystic duct, this is the cystic duct. You would have your common hepatic duct somewhere here. This would be the common hepatic duct, and this is the inferior edge of the liver. This is the liver which you can see. So this is the entire triangle which we've dissected, and this is also known as the critical view of lap chole. So every time you're doing a lap chole, your dissection should be in such a way that you can delineate all the structures before you start clipping them, so that you don't cause inadvertent injury to the biliary tree. Now, another point which I want you to remember, I told you cystic artery is a branch of the right hepatic artery. Sometimes what can happen, sometimes the right hepatic artery can have a tortuous course. Sometimes the right hepatic artery can have a tortuous course, and it can lie in the hepatocystic triangle. So you can see here that it has a tortuous course and it is lying in the triangle where we are dissecting. So what is the importance of this? This right hepatic artery can get injured. Right hepatic artery injury can be there, and that can give rise to bleeding. And this abnormality of the right hepatic artery, or this variation of the right hepatic artery, is known as the Moynihan's hump. This is the Moynihan's hump. This has also been asked in the exam. Moynihan's hump is when the right hepatic artery has a tortuous course and it lies in the area where you're going to dissect for the Callett's and the hepatocystic triangle, and this can get injured and there can be hemorrhage during surgery. So that's another thing which you should know. This is Moynihan's hump. Now, there can be certain anatomical variations which can be there in gallbladder, and one of the most common anatomical variations is a Phrygian cap. Anomaly. And this Phrygian cap was a cap which was worn during the French Revolution, and the gallbladder resembles the shape of this Phrygian cap. Now, please remember that this is just an anatomical variation. It is not an indication for surgery. It is not an indication for surgery. Okay. So these were the points regarding the basic anatomy and the relevant surgical anatomy which you need to know during lap chole and when you're examining a patient with obstructive jaundice or GB cancer. Now, the most important topic in gallbladder is gallstones, and invariably there is one question which is asked from gallstones every time in the exam. So let's talk about gallstones now. So gallstones, we're talking about the types of gallstones first, and the various types of gallstones. You can have cholesterol stones. These are usually solitary. These cholesterol stones are usually solitary, and they have more than 90% cholesterol content in them. They're also known as a cholesterol solitaire because they're solitary and big. Right? You can have pigment stones. There can be pigment stones which can be present. And Bailey clearly writes pigment stones are the most common in Asia, thereby India as well. So pigment stones are the most common stones in Asia. And pigment stones can be of two types. You can either have brown pigment stones or they can be black pigment stones. Now, brown pigment stones are the ones which are formed in infected bile. They can be formed in infected bile. They can even be formed in CBD. So the composition is calcium palmitate, calcium stearate, and calcium bilirubinate. Right? That is the composition of brown pigment stones, and they're formed in infected bile, I've told you. And the predisposing factors can be clonorchis, can be clonorchis infection or ascariasis or ascaris infestation, which can give rise to formation of these brown pigment stones. It can be secondary to cholangitis as well. Black pigment stones, on the other hand, black pigment stones are seen in hemolytic conditions. They are seen in hemolytic disorders, and the hemolytic disorders in which they are seen can be G6PD deficiency, can be G6BD deficiency, it can be hereditary spherocytosis, and sickle cell anemia. And the composition of black pigment stones, it is composed of insoluble bilirubin pigment polymer. There is insoluble bilirubin pigment polymer of calcium phosphate and calcium bicarbonate. So that is the composition of black pigment stones. And pigment stones, you need to know, pigment stones will have less than 40% cholesterol in them, will have less than 40% cholesterol content in them. And finally, you have mixed stones. Mixed stones are a combination of cholesterol and pigment stones. So these are mixed stones, and mixed stones are the most common stones all over the world. Most common stones overall are mixed stones. So this is another thing which you need to know. This has also been asked in the exam. This was regarding the various types of gallstones which are there. And if we look at the gallstones, you can see cholesterol stones, pigment stones. These are black pigment stones, and these are mixed stones, right? Whenever you have multifaceted stones, you can see that there are multiple surfaces. So you should always suspect that there'll be multiple stones, right? So that is how they are arranged in the gallbladder. So sometimes if you see a multifaceted stone and you see a single stone in the gallbladder which is multifaceted, you should always suspect that probably one or more stones have slipped into the CBD and gone down. So that's just gives you a rough idea whether there will be a single stone or multiple stones present. Now, what are the risk factors for gallstone formation? So what are the risk factors for gallstone formation? So basically we need 3 factors for stone formation, right? You need lithogenic bile. That means you need a supersaturated bile. You need stasis, and then there needs to be nucleation of the stones, right? Initiation or nucleation of the stones. Now, nucleation of the stone is secondary to infections, can be infections, and this we've already covered. Clonorchis can predispose to this, cholangitis can predispose to this, or ascariasis can predispose to this. Right? Where can we get lithogenic bile? So lithogenic bile can be seen in obese patients. If there is increased cholesterol in the blood, so hypercholesterolemia can give rise to this. This can be post-ileal resection. Post-ileal resection also, lithogenic bile can be seen. Post-ileal resection also. So post-ileal resection also, lithogenic bile can be seen. Now, where all can stasis occur? So stasis can be seen during pregnancy. Stasis can be seen during pregnancy. Oral contraceptive pills can give rise to stasis. TPN, total parenteral nutrition, can give rise to stasis. Rapid weight loss following a bariatric surgery can also give rise to stasis. So these are some conditions which can predispose the patient to gallstone formation. One more cause of stasis which we've discussed in the gastric module is post-vagotomy. If the nerve supplying the gallbladder is cut, then there'll be gallbladder stasis. So these are the conditions which can predispose to gallstones, and we've already discussed the types of gallstones which can be there. Another thing which I want you to know before I talk about the manifestations of gallstones is that 90% gallstones are radiolucent as compared to 90% renal stones which are radio-opaque. Only 10% gallstones are radio-opaque. Only 10% gallstones are radio-opaque. Therefore, the investigation of choice, and this is very important, the investigation of choice for gallstones, this has been asked in many, many exams, is an ultrasound, right? It is an ultrasound. And what do we find in an ultrasound is something which I want you to know. Gallstones will always cause, so look, this is the gallbladder, and stones will cast a post-acoustic shadow. Whether these are stones in the gallbladder or they are stones in the kidney, there will always be a shadow. You can see here, stone is casting a post-acoustic shadow. This ultrasound was asked in the FMG exam, and they had asked to identify what is the condition. So gallstones was the condition. Now, if you compare it with the GB polyp on ultrasound, there is no shadow. There is no shadow. So that is how you can differentiate a mass inside the gallbladder versus a gallstone. And you should all know this sign. Now, radio opaque gallstones are only 10%. They're only 10%. But you can get two signs in radio opaque gallstones. So you can see here on X-ray, you can see the radio opaque gallstones. Now, if it is a biradiate gallstone, then you get a seagull sign. You get a seagull sign. Or if it's a triradiate gallstone, then you can get a Mercedes-Benz sign. If it's a triradiate stone, then you can get a Mercedes-Benz sign. So these are the two signs which are seen in radio opaque gallstones, but they are only 10%. Okay. Let's talk about the various presentations of gallstones, because they've been asked multiple times. Each and every presentation of gallstone has been asked in the exam. So the first presentation is asymptomatic or incidentally detected stones. Asymptomatic or incidentally detected stones. As we've been discussing previously as well, that because of so much of preventive health checkups happening, patients get routine ultrasounds done, and sometimes they can be picked up with gallstones. Right? Now, when they're picked up with gallstones, how do we manage these patients? Now, if these patients are asymptomatic, no surgery is required. No surgical intervention. No surgical intervention is required except in the following conditions. So no surgical intervention for asymptomatic stones except in the following conditions. What are these conditions? So these conditions are if these patients are Salmonella typhi carriers, right? Or if these patients have porcelain gallbladder, if they have porcelain gallbladder with stones. What is porcelain gallbladder? You can see here, porcelain gallbladder is calcification of the wall of the gallbladder, and you can see a calcified GB, and this is said to increase the risk of malignancy, which is why even if they have asymptomatic stones, we'll carry out a cholecystectomy. Although latest Bailey has said that the actual risk of porcelain gallbladders developing into malignancy is less than 5%, but we still do a cholecystectomy if porcelain GB is there. The next exception to the rule is if there are GB polyps, with stones. Now, gallbladder polyps are also premalignant in nature. We'll talk about them later. So if gallbladder polyps are present along with stones, that's also an indication to carry out cholecystectomy in these patients. Now, if these patients have multiple small stones, then the problem is that one of these stones might slip into the CBD, go down and cause pancreatitis as well. So that is also an indication. If the stone size is more than 2 centimeters, then also a cholecystectomy should be contemplated in these patients. If these patients are undergoing bariatric surgery, that is also an indication to carry out cholecystectomy even if they are asymptomatic stones. If these patients have diabetes mellitus, because in diabetes mellitus patients, the first attack of cholecystitis can be their last attack because it can be quite severe. So a cholecystectomy should be done in these patients as well. And another relative indication is if they're coming from an endemic zone of GB cancer. endemic zone of GB cancer, which in our country is the Gangetic Plains, the UP and the Bihar belt. The Gangetic Plain is the endemic zone. So these are the indications to carry out cholecystectomy. In fact, if you read about the space program, the initial NASA program, when it started initially, some of the astronauts underwent a prophylactic appendicectomy, and if they also had asymptomatic gallstones, a cholecystectomy was done because, they didn't want the astronaut to suffer from appendicitis or cholecystitis in space. They had bigger problems to deal with up in space. So anyways, these are the indications to carry out cholecystectomy in asymptomatic stones. That was the first presentation which you should know about. The second presentation which we're going to talk about is acute cholecystitis. Now, acute cholecystitis, as the name suggests, is inflammation of the gallbladder. And the clinical features with which the patients are going to present, the clinical features or the symptoms which the patient is going to present, there's going to be right upper abdominal pain. Right upper abdominal pain is how the patient is going to come to the emergency. It's going to be associated with nausea and vomiting as well. On examination, when we examine a patient with cholecystitis, there'll be tenderness in the right hypochondrium. And there are two signs which you should know about. First sign is the Murphy's sign. And the other one is the Boas sign. Now, what exactly is Murphy's sign? Now, Murphy's sign is not tenderness in the right hypochondrium. Mind you, it's not tenderness in the right hypochondrium. Murphy's sign is we ask patient to take a deep breath. And we press in the right hypochondrium. Okay. Now, when we do this, when the patient is taking a deep breath and we press in the right hypochondrium, because of pain, the patient is suddenly going to catch his breath. He's going to hold his breath. And that is Murphy's sign. So the patient catches his or her breath. And that is Murphy's sign. Boas sign, on the other hand, is hyperesthesia. In the region of the 12th rib. That is Boas sign. Now, I've already told you the investigation of choice for GB stones, acute cholecystitis, and chronic cholecystitis. All three is ultrasound, and all three have been asked in the exam. So please remember, ultrasound is the investigation of choice. I've already told you what you will see. You will see a post-acoustic shadow, and you will see thickness in the GB wall. So another investigation is HIDA scan. HIDA scan is hepatobiliary. It is hepatobiliary immunodiacetic diacetic acid scan. And this is a nuclear medicine scan. And when you give this compound within 30 minutes, it comes into the gallbladder in almost 90% cases, and within 90 minutes, it comes into the bowel. Within 30 minutes, it localizes into the gallbladder. Within 90 minutes, into the bowel. Now, in acute cholecystitis, what happens? That the neck of the gallbladder is inflamed. There is inflammation. So because the neck is inflamed, it does not allow this dye to come inside the gallbladder. It does not allow the dye to come inside, which is why in acute cholecystitis, you get non-visualization of the gallbladder. Non-visualization of the gallbladder on HIDA scan. That is the sign which you see. You should remember this scan. HIDA scan is also used for diagnosis of biliary atresia, and we'll talk about this later when I talk about extrahepatic biliary atresia. Okay. So still the investigation of choice remains an ultrasound. Now, how do we manage patients with acute cholecystitis? So the management is based on the Tokyo Consensus Guidelines. So these are the latest Tokyo Consensus Guidelines which are given in Bailey as well. You have mild, moderate and severe. Let's start with severe first. So grade 3 is severe, and I don't want you to remember details. I just want you to remember a simple thing. I just want you to remember severe cholecystitis is moderate cholecystitis plus organ dysfunction. If organ dysfunction, you can see that is severe cholecystitis. That is what I want you to remember. Grade 2 is moderate acute cholecystitis, and moderate acute is if any one of the following things are met. And what are the things which we are looking at? If the WBC count is more than 18,000, if the duration is more than 72 hours, if there is gangrenous coli, abscess, or emphysematous coli, right? These are going to make it a moderate cholecystitis. More than 72 hours, WBC count more than 18,000, a palpable lump, emphysematous coli, and gangrenous cholecystitis. All these are moderate features. And one is mild, which does not meet criteria of 2 and 3. Which does not meet criteria of 2 and 3. So please remember that Tokyo Consensus Guidelines tells us about the severity of acute cholecystitis. You should remember the name. Tokyo Consensus Guidelines. Now, the management of any patient with acute cholecystitis. So the management, the first thing is you make the patient nil per oral. Don't give anything by mouth, otherwise they keep on vomiting, right? Nil per oral. Give IV fluids to these patients. We have to give IV antibiotics to these patients. And IV antibiotics should cover both gram-negative, and should cover anaerobes. And you need to give these patients painkillers also. You don't let them suffer in pain. You give them painkillers and analgesics as well. That is the initial management. Then you assess if patient presents within 2 to 3 days, or the patient has come after 3 days or after 72 hours. If the patient presents within 2 to 3 days, then we can carry out an emergency cholecystectomy. This is known as the golden period, and we can carry out an emergency cholecystectomy in these patients, right? Whereas if the patient comes after 3 days, this was the same thing which we discussed in appendicitis also. If the patient comes late, then everything is jumbled up. You'll have the bowel stuck to the gallbladder, you'll have the omentum stuck to the gallbladder, and if you try to do surgery, then you can cause more harm, you can cause more injury than good. So here, if it's after 3 days, then you do conservative management. You discharge the patient, and like we discussed in acute appendicitis, we call the patient after 6 weeks. After 6 weeks, we call the patient for an interval cholecystectomy. That's what we do. Okay. Now, if you are doing emergency cholecystectomy, lap chole is safe. Lap chole is safe in emergency setting also. The only thing which Bailey mentions is that there is a higher conversion rate to open surgery. Normally, lap getting converted to open is around 4%. But if you're doing it in the emergency setting, that the conversion rate is slightly higher because you might have more adhesions, more problem in dissecting, and you might need to open up the case. So this is the management of acute cholecystitis, which you should know about. And this we were talking about acute calculous cholecystitis. There is another entity known as acute acalculous cholecystitis. And this has also been asked in the exam, acute acalculous cholecystitis. That means there won't be any stone there. And what are the risk factors for acute acalculous cholecystitis? The risk factors, this can be seen in patients receiving prolonged TPN. Because in prolonged TPN, there can be cholestasis. We've discussed this. This can be post-burns. It can be seen in ICU patients. Post-coronary artery bypass grafting, post-CABG patients can also develop acute acalculous cholecystitis. It can also be seen if there is prolonged fasting. Now, the clinical features are going to be the same as acute calculous cholecystitis, which we've already discussed. The investigation of choice also here remains ultrasound only. And ultrasound will show you a thickened gallbladder wall and inflammation, but you won't see any stone. There won't be any stone, but you'll see thickened gallbladder wall and features of inflammation are going to be there. Now, the management of these patients, you again make the patient NPO, give IV fluids, give IV antibiotics, give analgesics. But these patients need to be taken up for an emergency cholecystectomy. These patients need to be taken up for an emergency cholecystectomy. If they are not responding to conservative treatment, do an emergency cholecystectomy. Sometimes what happens, sometimes patient is very sick to undergo cholecystectomy. And if the patient is very sick to undergo cholecystectomy, then the bailout procedure here is known as tube cholecystostomy. We do a temporary measure known as tube cholecystostomy. So what we do is that this is the liver, this is the gallbladder. This is the gallbladder. Under ultrasound guidance, we will just put in a tube inside the gallbladder. Right? We can put in a tube inside the gallbladder to decompress the gallbladder. To decompress the gallbladder, we can put in a tube, and when the patient's condition improves, then we can take up the patient for cholecystectomy. So tube cholecystostomy is only done in very sick patient, and it's a kind of a bailout procedure for us. So this was regarding acute acalculous cholecystitis. Now the third presentation is chronic cholecystitis. The third presentation is chronic cholecystitis. Chronic cholecystitis is when multiple episodes of acute cholecystitis develop. Patient can develop chronic cholecystitis. On ultrasound, you get a very characteristic sign, and I want you to know this sign. This has been asked in the exam. This is known as the wall echo shadow sign. Wall echo shadow sign. WES sign. This is seen in chronic cholecystitis, wall echo shadow sign. What this means is that the wall is thickened. The wall is thickened, and you have an echogenic stone which is going to cast a shadow. These are the features of wall echo shadow sign seen in chronic cholecystitis. You should know this. Right? So you get wall echo shadow sign. I've just told you the sign which is seen. The management is lap cholecystectomy has to be done. And when you do a histopathology in chronic cholecystitis, you can get Rokitansky-Ashkoff sinuses. You can get Rokitansky-Ashkoff sinuses in chronic cholecystitis. And you need to know that if these Rokitansky-Ashkoff sinuses are commonly seen in patients with chronic cholecystitis, if these Rokitansky-Ashkoff sinuses rupture, they can give rise to xanthogranulomatous. They can give rise to xanthogranulomatous cholecystitis. So please remember, if they rupture, they can give rise to xanthogranulomatous cholecystitis. That was regarding chronic cholecystitis, which is the third presentation. The fourth presentation is emphysematous cholecystitis. Emphysematous cholecystitis. So as the name suggests, there is going to be gas formation here. So the organism responsible for emphysematous cholecystitis are Clostridium species. Right? So Clostridium is responsible for emphysematous cholecystitis. This is seen in immunocompromised patients. This is seen in immunocompromised patients, quite common in diabetic patients as well. Now, the point which I want you to remember here is that emphysematous cholecystitis is due to Clostridium species. But emphysematous pyelonephritis, and this I've covered in the kidney chapter, emphysematous pyelonephritis is due to E. coli. So don't get confused between the two. Emphysematous coli is Clostridium. Emphysematous pyelonephritis is E. coli. And these patients, the clinical features, patient is going to come with pain. There will be fever, and these patients are usually in a state of sepsis. So that is very important. They will be in a state of sepsis. And in these patients, you will either see gas within the gallbladder or in the wall of the gallbladder. So you can see here that there is gas. You can see gas within the gallbladder, and you can see in the wall of the gallbladder as well. That is diagnostic of emphysematous cholecystitis. The investigation of choice will of course be ultrasound, or you can even do a CT if the patient is stable. And the management here is again emergency cholecystectomy. Again, if the patient is very sick, like we discussed in Like we discussed in acalculous cholecystitis, if the patient is very sick and cannot tolerate an emergency cholecystectomy, then we can do a tube cholecystostomy. Then a tube cholecystostomy can be done in these patients. So this was the fourth presentation. The fifth presentation, which I want you to know, is a mucocele of the gallbladder. Now, what exactly is a mucocele of the gallbladder? Well, mucocele is, this is the gallbladder. Now, if a stone gets impacted at the Hartmann's pouch, right? In mucocele, stone gets impacted at Hartmann's pouch or the neck, at Hartmann's pouch. And when the stone gets impacted at the Hartmann's pouch, all the bile gets absorbed. So bile gets absorbed and mucin is secreted. So the entire gallbladder will be filled with mucin, right? And it will be enlarged. The diagnosis can be made on an ultrasound, and the management of these patients is lap cholecystectomy. Right? So you should know the definition. Stone gets impacted at the Hartmann's pouch or the neck, and bile gets absorbed and mucin gets secreted. If mucocele becomes infected, so mucocele, you need to remember, mucocele is aseptic dilatation. Of the gallbladder. There is no infection, it is aseptic. But if mucocele gets infected, it gives rise to empyema of the gallbladder. It is going to give rise to empyema of the gallbladder. The treatment remains the same. You need to carry out a lap cholecystectomy, but instead of mucin here, now you're going to get pus inside the gallbladder. The next presentation of gallstones is Mirizi's syndrome. So this is the sixth presentation, Mirizi's syndrome. Now in Mirizi's syndrome, what happens? Due to inflammation, gallbladder becomes adherent to the CBD. And the stone inside GB presses on CBD, right? So what has happened is that due to inflammation, there has been inflammation, and because of this inflammation, this stone which is there, this stone is now putting pressure on the CBD, and because of this pressure in the CBD, what will be the clinical features? The clinical features of these patients, they can present with obstructive jaundice. They can come with obstructive jaundice because the CBD is getting pressed, and there can be features of cholecystitis as well. Now, Mirizi's, the final stage of Mirizi's, and this has also been asked in the exam, the final stage of Mirizi's is when a fistula forms. Between the gallbladder and CBD. So now what is going to happen? You will have two openings. One will be this fistulous opening. So if you look here, so what is going to happen? One is going to be the opening of the cystic duct. One is your opening of the cystic duct which is there. And another opening will form between the gallbladder and the CBD due to a fistula, right? And that is Mirizi's syndrome. The investigation of choice for Mirizi's syndrome is MRCP. What is MRCP? MRCP is magnetic resonance. Cholangiopancreaticography. Magnetic resonance cholangiopancreaticography is MRCP, and this will tell us if a fistula has formed or not. The management of these patients with Mirizi's syndrome is that you have to carry out a lap cholecystectomy. We have to do a cholecystectomy in these patients, but sometimes GB is densely adherent. Sometimes the GB is densely adherent to CBD. And if the gallbladder is densely adherent to the CBD, if you try to remove it, you might create a bigger tear in the CBD. So if it is densely adherent, then in these cases, we carry out a partial cholecystectomy. We remove as much of the gallbladder as possible, and we leave some portion of the gallbladder adherent with the CBD, and we close the cystic duct opening and we close the fistulous opening as well. So we leave some portion of the gallbladder adherent and we close both the openings so that there is no bile leak. This was Mireille's syndrome, which you should know about. The next presentation of gallstones is gallstone ileus. And gallstone ileus, as the name suggests, this is a type of bowel obstruction. And ileus is a misnomer because gallstone ileus is a type of dynamic bowel obstruction. It is a type of dynamic bowel obstruction. Now we've already covered dynamic and adynamic bowel obstruction in the bowel obstruction module. So there is something physically which is going to obstruct the bowel here, and that physical obstruction in this case is caused by the gallstone. Now, how does gallstone ileus occur? It occurs secondary to a cholecystoduodenal fistula. It occurs secondary to a cholecystoduodenal fistula. What do we mean by that? So look here, please. This is the gallbladder. This is the opening of the gallbladder. This is our duodenum. This is the stomach. And this is the duodenum. So what happens due to inflammation? Due to inflammation, gallbladder becomes adherent to duodenum. So the gallbladder has become adherent to the duodenum, and because it becomes adherent, a fistula forms. A fistula forms between the gallbladder and the duodenum, and the stone comes here, and now it can travel down and cause obstruction. So one thing which I clearly want you to remember is that gallstone ileus will not occur if the stone is coming down the CBD. This stone will not cause gallstone ileus, right? It can cause other problems and we'll talk about them, but won't cause gallstone ileus. Obstruction of the bowel will only occur if there's a cholecystoduodenal fistula. Now, the most common site of obstruction, this has been asked many times in the exam, it is not the ileocecal junction. Mind you, it is not the ileocecal junction. It is the terminal 2 feet of ileum. It is the terminal 2 feet of ileum, which is the most common site of obstruction in gallstone ileus. Another term which you should remember is Bouveret syndrome. Bouveret syndrome is when the stone leads to gastric outlet obstruction. In some cases, it can give rise to gastric outlet obstruction, and that is known as Bouveret syndrome. We already know the clinical features of bowel obstruction. Patient is going to come with distension. Patient is going to come with distension, obstipation, that is non-passage of flatus and feces. There is going to be abdominal pain, and there is going to be vomiting. So these are the clinical features with which the patient is going to present. Now, you know the initial investigation. You know that the initial investigation in bowel obstruction is an X-ray abdomen. We've discussed this multiple times. Now, when you do this X-ray abdomen, in these patients, you will get a Rigler's triad. Rigler's triad has been asked multiple times in the exam. Now, Rigler's triad is pneumobilia. There is going to be pneumobilia because of the fistula. Gas from the bowel comes into the biliary tree. That is pneumobilia is going to be there. There will be features of small intestinal obstruction. You will have dilated bowel loops, you will have air fluid levels, and you will have a radio-opaque shadow. There will be a radio-opaque shadow in right iliac fossa. Right? Now, you might be wondering that a gallstone, only 10% are radio-opaque. So how come it's showing up on an X-ray? Well, what happens is that these stones, when they travel down, they get coated by calcium salts in the bowel. And when they get coated by calcium salts in the bowel, they will appear radiopaque. So these are the three features of Wriggler's triad: pneumobilia, features of small intestinal obstruction, and a radiopaque shadow in the right iliac fossa. The investigation of choice is a CECT, that is a contrast enhanced CT scan. And the management of patients with bowel obstruction, make the patient nilperoral, give IV fluids, nasogastric decompression. You need to give antibiotics and then take up the patient for surgery. Now, when we do surgery in these patients, there can be two scenarios. Scenario number one is that there are no features of peritonitis, no features of strangulation. There are no features of peritonitis, no features of strangulation. Two things can be done here. Either we can milk the stone beyond ileocecal junction. Some people like to crush the stone, right? They just crush the stone and get the fragments across the ICJ. Or some people like to do an enterotomy and remove the stone. You make a small nick in the bowel, remove the stone. These are done when there's no perforation, when there's no strangulation or any peritonitis. But the second scenario is that this patient has a perforation. If there is a perforation or there is strangulation, then in this case, the surgery which would be carried out would be resection and anastomosis. Please remember another very important point. Is that surgery for gallstones and the fistula is done later as a second procedure. We don't do it in the emergency setting. It is usually done after 4 to 6 weeks. We do another surgery to deal with the gallstones, the gallbladder and the fistula which is there. Right, so this was the next presentation of gallstones which you should know about. Now the next one is also very important. The next presentation of gallstones is choledocholithiasis. Or stone in the CBD, or if you have stone in CBD. So now we're going to talk about choledocholithiasis or stones in the CBD. So what happens is that if you have a stone in the gallbladder, that can sometimes slip into the CBD, right? So you have a stone here and this stone can slip into the CBD and that is known as choledocholithiasis. In 10% cases, you can have primary CBD stone as well, where the stone forms within the CBD, but majority of the cases it is going to be a gallbladder stone which spills down into the CBD. Now, when this happens, what are the clinical features? So, a lot of patients can be asymptomatic. These patients can, because of obstruction of the stone, sometimes the stone can cause obstruction. There can be obstructive jaundice which can be there. Which can occur, and because of stasis, sometimes there can be infection and it can give rise to cholangitis, that is inflammation of the CBD and the biliary tree. And cholangitis presents as Charcot's triad. This has been asked many times in the exam. Charcot's triad, the clinical features of Charcot's triad are intermittent pain, fever and jaundice. Intermittent pain, intermittent fever, intermittent jaundice. And the reason behind this is because the stone keeps on moving in position. So sometimes there's going to be jaundice, then it moves, the jaundice gets relieved, then again jaundice can occur. So intermittent pain, fever and jaundice is Charcot's triad. Sometimes they've also asked what is Raynaud's pentad, which can be seen in cholangitis. Raynaud's pentad is Charcot's triad. It is Charcot's triad plus shock plus altered mental status. This is Raynaud's pentad. So these are the various presentations how a patient with a CBD stone can present. Now the investigation of choice for a CBD stone, The investigation of choice for a CBD stone is MRCP. MRCP, I've already told you, it is a type of an MRI. This is magnetic resonance cholangiopancreatography. And you can see here, you can see a stone here in the CBD. You can see a stone here. Sometimes you should also know that an air bubble can also be confused for a stone. So the investigation of choice for CBD stones is MRCP, but Bailey has written that the investigation of choice for CBD microliths, very small microliths in the CBD, it is endoscopic ultrasound, EUS. So please read the question and then mark the answer. Now, how do we manage a patient with a CBD stone? This is important. How do we do the management of a patient with CBD stone? So I'm going to cover 3 scenarios. Right? 3 scenarios, and these are 3 practical scenarios. The questions are also asked this way only. Scenario number 1 is when the CBD stone is detected along with gallstones, along with GB stones before cholecystectomy. Before cholecystectomy. So this is the ideal scenario. Here what we have is that when the ultrasound was done, the radiologist found that there were gallstones, but they also saw that the CBD was dilated. And because the CBD was dilated, they were suspecting CBD stones. They did an MRCP and they found out that there are gallstones also and there are CBD stones also. So this has been asked in the exam. How do you ideally manage such a patient where stones are detected before surgery? So the ideal management for these patients is ERCP plus sphincterotomy. ERCP plus sphincterotomy, followed by lap chole after a few days. Followed by lap cholecystectomy after a few days. This is the treatment. Now, what is ERCP? ERCP is endoscopic retrograde cholangiopancreatography. This has been asked many times. It is endoscopic retrograde cholangiopancreatography, that is ERCP. Right, so in ERCP what we do is we put in a scope, right? We put in a scope. You can see the scope coming here. You can see the scope, and that is how you can differentiate ERCP from an MRCP film. And in ERCP we always use a side viewing duodenoscope. This also they've asked. A side viewing duodenoscope, so that we can see on the side viewing duodenoscope is used here. And then we inject a dye, and then this dye can delineate the anatomy of the biliary tree, and we can even see stones. So the same information which I was getting in MRCP, I am getting in ERCP also. But the advantage of ERCP is that this is both diagnostic and therapeutic. I can even do a therapeutic intervention and I can remove the stone as well. So this is diagnostic plus therapeutic. ERCP is diagnostic plus therapeutic, right? So what do? We make a cut in the sphincter. We make a cut in the sphincter, and the cut is made at 11 o'clock position. This also has been asked in one of the exams. The cut is made at 11 o'clock position, and then we can retrieve the stones either using a Dormia basket, which I told you in renal stones as well, or you can break up the stone and then retrieve the fragments. So the cut is made at 11 o'clock, and you should also know the complications of ERCP. They have also been asked in the exam. The most common complication of ERCP is ERCP-induced pancreatitis. This has been asked in multiple exams. So ERCP can give rise to pancreatitis. And the second most common complication is duodenal perforation. So you should remember these 2 complications of ERCP. They've also been asked. You should be able to identify the investigation. And I've told you to differentiate. You'll see the scope here. So if you see the scope, this is an ERCP film and not an MRCP one. So this is the first scenario. If you're picking up stones before surgery, do an ERCP, remove the stone. After a few days, do a laparoscopic cholecystectomy. That is the ideal management. The second scenario is when CBD stone is detected CBD stone detected. CBD stone is detected during surgery, that is during lap chole. The surgeon figures out for the first time that there is a stone in the CBD. So the reason why I'm laughing is that you know that the first year resident, when they join the surgery residency, for around 6 months or so, their work is just to work up patients and send them to the theater and other people operate those patients. So sometimes the work can get frustrating and sometimes, you know, you get overburdened with work and you miss out on small things. So I'll share an actual case example where I was a third year postgraduate. I was assisting my senior resident who was doing a lap chole, and we opened up the case. We saw that the CBD was dilated, and when he just felt there, he could even feel that there are some stones inside the CBD. So, you know, the first year resident was summoned into the theater, and the first year resident was asked that, did you check his investigations? And the first year resident, as apologetic as he could be, he said, sir, I was overburdened with work and I missed out on certain small things. And what were the small things which the first year postgraduate missed out on? He forgot to see the liver function tests. So there was raised ALP. He forgot to take a history. History of jaundice was not taken. And the ultrasound showed that the CBD was more than 10 millimeters in diameter. So the CBD was dilated. These are the three things which point towards a CBD stone. These are the three indicators that there might be a CBD stone present in a patient with gallstones. So one should always look at these three things at least before they are doing a lap cholecystectomy. And if these things are present, the patient should have an MRCP to confirm whether the stone is there or not. Any which way, stone was missed, detected during surgery. Now how do we manage this stone? So if the stone is detected during surgery, we have to carry out laparoscopic cholecystectomy. We do lap chole, plus we do lap exploration of CBD. Plus we do lap exploration of CBD and we remove the stones. If lap exploration of CBD is not possible, then we carry out open exploration of CBD. Then we carry out open exploration of CBD. There is one point which I always want to tell you here. This is very important. Whenever you are exploring the CBD, if you make a cut in the CBD, it should always be a longitudinal cut. It should always be a longitudinal cut, never a transverse cut. Why not a transverse cut? Because if you make a transverse cut, when it heals, it will form a stricture. So always a longitudinal cut. And never at 3 and 9 o'clock. Never at 3 and 9 o'clock, because the blood supply comes from 3 and 9 o'clock. The blood supply comes from the side, so you don't make a cut there, otherwise again a stricture can form. These are two things which you need to be careful about when you are making a cut in the CBD for exploration. This you should be careful about. Now once you've removed the stones, right? You know, the choledocholithotomy forceps, I've already shown you in the instruments that choledocholithotomy forceps will be used to remove or retrieve these stones. Once we have done that, then we insert a T-tube. Now, what is a T-tube? This is what a T-tube looks like. It's in the shape of a T, and we put it inside the CBD. So this is the CBD and this is my T-tube. I'm going to put the T-tube through the skin into the CBD and one end comes outside. This is a T-tube. The reason I put in a T-tube is A, it will keep on decompressing the bile. That is one help which it is going to give me. And then what we do is after this T-tube, after 7 to 10 days, After 7 to 10 days, I'm going to inject dye through this tube. This is known as a T-tube cholangiogram. This is known as a T-tube cholangiogram. So this dye is going to delineate the anatomy of the biliary tree, and it will tell me if residual stones are there or not, if stones are present or they are not present, right? I've already told you that air bubbles sometimes can also mimic stones, so one should be careful. So after 7 to 10 days, we do a T-tube cholangiogram. And if no residual stones are there, we remove the T-tube. But if residual stones are present, then in this case, we retain the T-tube. We retain the T-tube for 3 to 4 weeks. And once we retain the tube for this long, a tract forms. A tract is going to form, and this tract would enable us to put in a choledocoscope. We can put in a scope through that tract, go into the CBD and remove the stones. We can remove the stones through the tract. So this technique of managing CBD stones using a T-tube, this technique is known as the Burheen technique. This has been mentioned in Bailey. You should know the Burheen technique. You should be able to identify the T-tube I've shown to you. And you should know that the T-tube cholangiogram is done after 7 to 10 days. So this was situation number 2 when we discovered stones during surgery. Now the third scenario is when stones are discovered, CBD stones after chole. CBD stones are detected after cholecystectomy. That is the third scenario. So you can have 2 types of stones here. You can either have residual CBD stones. Residual CBD stones can be there, or you can have recurrent CBD stones. Or there can be recurrent CBD stones. Now, residual CBD stones are those stones which are found within 2 years of lap chole. Recurrent are which are seen after 2 years of lap chole. So residual are which are seen within 2 years. Recurrent are which are seen after 2 years of lap chole. And recurrent CBD stones, the causes for recurrent CBD stones can be primary CBD stone can form. Primary CBD stone, and this usually forms due to clonorchis or due to ascaris or due to cholangitis. And MRCP again will pick up these stones, and the management of these stones would be ERCP plus sphincterotomy. And we remove the stone. Now, when we do ERCP plus sphincterotomy, we can remove a stone up till 1.5 centimeter in size. But if there is a bigger stone than this, then it is an issue. Then the stone can sometimes become impacted and it does not come out. If ERCP plus sphincterotomy fails, then what we need to do is we need to do a transduodenal sphincterotomy. So transduodenal sphincterotomy, as the name suggests, I cut the duodenum, I see the sphincter, I cut the sphincter under vision. Under vision, I cut the sphincter and then I retrieve the stone. This way I can retrieve a bigger stone. If this fails or stone is impacted higher up, then we need to carry out a supraduodenal choledochotomy. That means make a longitudinal incision in the CBD itself. And remove the stone. I've already told you, incision in the CBD should be longitudinal, should not be transverse, should be avoided at 3 and 9 o'clock. And when we are suturing the CBD, suturing the CBD, we will always use an absorbable suture. Here. It is usually Vicryl or PDS. because if we use a non-absorbable suture, it will remain there lifelong, and it can act as a nidus for stone formation. And knots should be outside the lumen. Knots should be outside the lumen, because if the knots are inside the lumen, then again that can give rise to problems, and it can act as a nidus for stone formation. So this is how we manage CBD stones. These are the points which you should know. CBD stones is a very important topic from the point of view of the exam. There are two more presentations of gallstones, gallstone pancreatitis, which I've covered in detail in the pancreatitis module. Just a word of advice here, that if you have a patient with gallstone pancreatitis, if stone is impacted and jaundice is increasing till 72 hours, then in these patients we should do ERCP and sphincterotomy, and we should remove the stone. And the second point which I want you to remember, this also I've highlighted in that module, before discharge from the hospital, patient should have a lap chole. Lap chole should be done so that multiple episodes of pancreatitis don't develop. And the final association of gallstones is with gallbladder cancer. So these were the various presentations of gallstones. Each and every one of it has been asked in the exam.